Okay, so let's change topics and talk about acute blood loss. So someone who's hemorrhaging, and we're usually referring to someone who's losing significant amounts of blood. So whether it's a significant gastrointestinal bleed, or someone's vomiting up tremendous amounts of blood, or someone's been in a car accident and they're internally hemorrhaging, such as from a splenic laceration or a liver laceration, or sometimes someone who's having very, very heavy uh, bleeding postpartum. So they've delivered um, a child and now the bleeding just won't stop. So think of significant blood loss when we're talking about this. So let's look at the left first, the compensatory mechanisms. What's your body going to do? And a lot of this is going to be from different mechanisms that we've already spoken about. So the first two, increased heart rate, increased cardiac output, that's the sympathetic nervous system. Peripheral vasoconstriction, that's the sympathetic nervous system, all in the hopes of maintaining blood pressure. Okay, so everything is geared towards maintaining blood pressure because the body needs that blood pressure to be maintained in order to continue circulation to all the vital organs, including the brain. Okay? Stimulation of ADH secretion, that's going to reabsorb fluid from the collecting ducts in the kidney. Okay, well, that's going to result in significantly reduced urinary output, but it's going to try and reabsorb all the fluid to try and maintain circulating volume. Activation of the renin-angiotensin-aldosterone system. Again, um, angiotensin 2 vasoconstricts the blood vessels to try and maintain blood pressure. Aldosterone reabsorbs salt or sodium and water to try and increase circulating blood volume. Okay? Decreased urine output, as I just mentioned, because all the fluid is being reabsorbed by ADH. The body doesn't want to get rid of any fluid because it senses hypotension. Okay, what's the other side of this slide? Stop the bleeding. Okay, so we're going to talk about the coagulation system. So there's platelet activation at the bleeding site. So whenever you injure a blood vessel, there's factors that get released, such as platelet activating factor, that tell the platelets to form an immediate plug to try and stop the bleeding very quickly. In fact, the first mechanism that occurs at a bleeding site is vasoconstriction. The blood vessel vasoconstricts to try and stop further bleeding, and then followed by that, the platelets try to form a platelet plug. Okay? And it's temporary, and it's not very strong. So what happens next? The coagulation system is activated. Okay? And the coagulation system will come to what forms at the end of the coagulation system is a very strong fibrin clot. Okay? And that, you could see that as a scab. Okay? So when you injure yourself and you have a scab that's formed, that's a fibrin clot. It's very strong. Okay? And that's going to stop any further bleeding, but it takes more time to form that fibrin clot compared to a platelet plug. And of course, if we were to check the bloodstream, if we were to do a CBC with someone who's hemorrhaging, hours later or the next day, we would definitely see an increased reticulocyte count. Okay, just because the bone marrow is responding by the bleeding, it's moving reticulocytes, which are immature red blood cells, more and more into the bloodstream. Okay, so this slide is showing you what we refer to as shock classification. And I would just look at it in a general sense. I I wouldn't try to memorize every number on this slide. I don't think it's realistic, but we use classes of shock just to give us an idea of what's occurring in the body, right? So class 1, less than 15% blood loss, class 2, class 3, class 4. 40% blood loss, by the way, in class 4. The average adult has 5 liters of blood. So you've lost 2 liters of blood in or greater in class 4 shock, okay? And you can see the response to the body. So I think this slide's interesting in showing what the body's doing as the blood loss continues, okay? So let's look at class 4 shock since it's going to be the most extreme. Well, the heart rate is going to do everything it can to increase and maintain cardiac output. So it's going to go, okay, it says greater than 140. In a young person that can generate a higher heart rate, could be 160, 170, 180 even, okay? The blood pressure is decreased. You've lost over 2 liters of blood. The cardiac output can't be maintained. The blood pressure cannot be maintained despite more cardiac output. Respiratory rate, you're breathing faster because the lungs are sensing this low blood pressure, and you're actually becoming acidotic as well because the cells now aren't receiving oxygen because of the low blood pressure. So you're becoming acidotic. What happens when you become acidotic? You also breathe faster. Okay. Next to no urine output because everything is being reabsorbed in the kidney into the bloodstream in terms of volume to maintain plasma volume. So ADH is reabsorbing as much as possible. Aldosterone is reabsorbing sodium to reabsorb water. Your mental status, well, your blood pressure's low, right? So you're going to be lethargic. You could even be unconscious if your blood pressure's low enough. Okay, so look at the spectrum of going from class 1 shock to class 4 shock. And you can imagine an older person that's in class 4 shock likely will not survive for many reasons. It can't generate a high heart rate. They can't maintain their blood pressure the same because they can't maintain a good cardiac output for very long. Okay, so now the other thing to take away from this slide is look at the urine output. We follow urine outputs very closely when we want to see how someone is responding to fluid. So if someone's in shock and we're giving them fluid or blood, we're going to put a Foley catheter in to see if they're making proper amounts of urine, right? They're now getting rid of fluid in the form of urine, and that's a good sign, okay? Because it means that the body is maintaining its plasma volume and it's willing to now start producing urine again. So just look at the slide, get a feel for the different classification levels of shock, and it's really based on how much blood have you lost. Okay, so let's look at the ABO blood typing system. So we all have a certain blood type, okay? And when we're talking about group A, group B, AB, or O, it's referring to what's on the red blood cell in terms of the antigen. So if you're group A blood, you have A antigens on your red blood cell. Group B, you have B antigens on your red blood cell. AB, you have both antigens on your red blood cell. And finally, group O, you don't have any antigens on your red blood cell. Okay, let's look at the plasma of that patient. Well, if you have group A blood, you have antibodies to group B blood. Okay, you don't want to get group B blood. okay, or type B blood. So you have the opposite antibodies in the bloodstream. So type B blood has antibodies to type A blood. Type AB blood, they don't have any antibodies. And if they did, they'd be attacking their own red blood cells. So they don't have any antibodies. And type O blood has both antibodies. Okay? Now, when we're giving a blood transfusion, it's the type of blood that matters the most. It's not the plasma that's in the donor blood. And I'll tell you why. Because we're giving packed red blood cells. Okay? So we've taken whole blood and we've separated it into different components. And if we're giving someone blood, like packed red blood cells, we're giving the type specific blood. Okay? So could it have a couple of antibodies in it from that patient's blood? Yes, but that's not going to cause a big reaction. The big reaction will come from giving someone the wrong type of blood. So for example, giving someone who's type A blood, giving them type B blood, that's going to set up a huge hemolytic reaction. Okay? So let's look at this and ask ourselves, who's the universal donor? Who can give blood to anyone? Well, group O, so type O blood, has no antigens on it. I can give it to anyone, okay? And they're not going to react to it. Okay, who's the universal recipient? Who can take blood from anyone? Well, group A blood can take type A blood or type B blood. Why? Because they don't have any antibodies in their bloodstream to attack type A or type B. Okay? In general, we try to give patients their specific type of blood. So someone who has AB blood, we try to give them AB blood as a transfusion. Okay, but just so you know the concept of universal donor and universal recipient. Okay, so in the emergency room, and someone's bleeding to death, and we don't have their specific blood ready and waiting, no problem. We can give them type O blood. Okay, because there's no antigens on it. So whatever blood group you are, you can receive type O blood. Okay, so I'm not going to spend too much time on the upper part of this slide, but just remember that red blood cells have antigens on them. So A antigens, potentially B antigens, or potentially none of them, right? So that'll determine your blood type. Now, there's also an Rh factor that's on red blood cells, okay? And if you have the Rh factor on your red blood cells, you're Rh positive. If you don't have the Rh factor on your red blood cells, you're Rh negative. Okay, so why does this matter? Well, it only matters in women that are of childbearing age. Okay, so let's take someone who is female, 25 years old, and they need blood. Well, we're going to check their blood type and say they're A negative. Okay, so if they're A negative, okay, well, we could give them A blood, or what else could we give them? We could give them O blood. Okay, those are the two blood types that they could accept. But we want to make sure that we give them Rh negative blood. If we give them, say, A positive blood or O positive blood, the Rh factor is going to set up an immune response in the 25-year-old woman, and that's going to make her sensitized to Rh factor. So if years later she gets pregnant and the fetus um, um, is Rh positive, which most of us are, 90% of us are Rh positive, well, some of the fetal blood always gets a bit into the maternal circulation. And now this woman who was given A positive blood is sensitized to the Rh factor and now can attack the fetal blood, okay? Because she was sensitized to the Rh factor from a blood transfusion. Okay, so to understand that concept, so we're careful in terms of giving Rh negative women of childbearing age. We make sure that we give them negative Rh blood. Okay, so for example, in a hospital, we have emergency blood, someone who needs it right away, and we don't have time for the lab to see what kind of blood type they are and get the blood ready. Well, we have O negative blood and we have O positive blood. Okay, so say a woman comes in who's 25 and she's bleeding to death and she's in shock. We don't even know what Rh status she is. We don't know if she's Rh positive or Rh negative. But we're just going to give her Rh negative blood. Because on the off chance that she's Rh negative, in terms of a blood type, we don't want to give her the Rh positive type blood and then sensitize her immune system to the Rh factor. Okay? I hope that makes sense. Okay, the other concept I want you to remember is type AB blood is a universal recipient. AB blood, if you look at the above slide, you can receive blood from anyone if you had to. O blood, A blood, B blood, or AB blood. O type blood can be given to anyone, so that's called a universal donor. So O blood can be given to any blood type in a patient, okay? And that's why we stock it in emergency rooms. Okay, I hope that makes sense. Okay, so let's talk some more about blood types. And if the above slide before this one made total sense, then you can skip this slide, okay? But let's look to the right of this slide and parent 1 and parent 2. So you get an allele from your mother and you get an allele from your father in terms of blood types, okay? And blood type, so the A allele or the B allele is dominant over the O allele. So if you're blood type A, for example, you could be AO or you could be AA, right? And you'll still be blood type A. So remember that in terms of the blood type O being a recessive allele, okay? So let's find an example here. The third one down is a parent with blood type A and another parent with blood type AB. What could the children be? Well, they could be A, they could be B, and they could be AB, okay? So how could they be B? Well, they could get the B allele from parent 2, and parent 1 could have been AO. So the person, the offspring with type B blood would be BO, okay? So just remember that you get an allele from your mother and you get an allele from your father. And if you're blood type B, you could be BO. If you're blood type B, you could be BB. And the same goes with blood type A. You could be AA or you could be AO. Okay. So let's look at the Punnett square on the left here. and see what the blood types are. So someone who on the left, so a parent is blood type O, well, then they definitely have both alleles that are O blood or O type blood. The other parent is AB, okay? So one of the alleles is A, one of the alleles is B. They're both co-dominant, so the person is blood type AB. Okay, what about the offspring? Well, none of them are going to be O, because in order to be O, you need both alleles to be O. So you have AO, well, that's blood type A. You have BO, that's blood type B. And the other offspring are the same, AO or BO, okay? Now, when we look at the RH type at the bottom right there, well, if both parents are RH positive, well, remember, there's two alleles. So parent 1 could have one allele that's positive for RH factor and one allele that's negative for RH factor. But they're still RH positive because the allele for RH factor is recessive if it's negative, and if it just takes one allele to be positive for you to be RH positive. And that's why when you look at the possible RH types of the child in the first example, they could be RH positive or they could be RH negative, because the first parent may have been one allele RH positive and the second allele RH negative. They're still RH positive. The second parent may have been RH positive and the second allele RH negative. So if the two RH negatives are given to the child, they are RH negative. Okay? So now the bottom one, parent 1 is RH negative, parent 2 is RH negative. Well, there's no way they're going to get an RH positive allele. Because if you're RH negative, it means both alleles are negative in the parents. So the children have to be RH negative. Okay, so let's look at some potential red blood cell transfusion reactions. So the first one is definitely the most severe, right? Someone has received the wrong blood type. And this is really uncommon because there's so many checks and balances. So the patient's blood is taken, it's typed at the lab to see exactly what blood type they have. The lab sends the blood back to the hospital or to wherever the patient is, and it's double checked by two nurses, right? And on top of that, the patient typically has a wristband to identify the patient and the label that's on the packed red blood cells. So it's very hard, it's very rare to get an acute hemolytic reaction because it's so dangerous, okay? So now when we're looking at a hemolytic reaction, it's typically going to happen quickly, okay? It's usually within the first 15 minutes. It can be a bit longer, but typically it's not because it's a massive reaction. So if you're blood type A and you get blood type B, what's going to happen? Well, you have antibodies in your bloodstream to blood type B. You have anti-B antibodies, and they're going to directly attack the blood transfusion, red blood cells, and destroy them, and you'll get massive hemolysis. Okay, so acute hemolytic reaction is from ABO incompatibilities. Okay, and it causes massive red blood cell destruction in the bloodstream. So they get hemoglobinuria leaking into their urine. They're going to get acute a renal failure, because of all of these broken up red blood cells that are blocking all the capillaries going to the kidneys, they're going to be hypotensive because of all the inflammation. Typically, patients present and they give us a warning that they suddenly have severe low back pain. That's a symptom of acute hemolytic reaction during a blood transfusion. And finally, it can lead to death because of massive hemolysis. Okay. Febrile reactions are relatively common during blood transfusions. And it's due to the fact that red blood cell transfusions still have some white blood cells within them. So they haven't been able to completely remove some of the white blood cells that are in the red blood cell package. Okay, and you get a reaction to the donor's white blood cells, okay, that are in the packed red cell transfusion. And it typically presents as fevers. Now, is that a reason to stop the transfusion? No. Typically, we'll give patients antihistamines such as diphenhydramine and acetaminophen for the fever. Okay? But the transfusion can still continue. Now, on the next transfusion, the red blood cell can be filtered even further to try and remove even more white blood cells, okay, to try and avoid this incompatibility and reaction to the donor white blood cells that are within the red blood cell transfusion, okay? And then finally, you can get minor allergies to some proteins that are still left in the donor blood that's in the red blood cell transfusion. And they can cause some fevers and rashes as well. And again, we can use antihistamines and acetaminophen. Okay. Remember, whenever there's a blood transfusion reaction, the first thing to do is stop the transfusion, check the vital signs. Okay. And because we really want to stop the transfusion if there's any potential for an acute hemolytic reaction. Okay, what else can happen with a blood transfusion? Well, you're giving volume, right? So red blood cells are coming in a bag, so you're giving a patient volume. So someone who's not able to tolerate increased circulating plasma volume can develop symptoms of shortness of breath. Say, for example, someone with congestive heart failure, and you give them blood transfusions and they go into pulmonary edema. They get short of breath, they're breathing fast. So how can we prevent this? Well, we can run the blood transfusion over a longer period of time. And the longest we'll run a red blood cell transfusion is 4 hours. So we can, if we know someone has congestive heart failure, we can run the transfusion over 4 hours to prevent fluid overload. Okay? What else can happen with a blood transfusion? Well, blood is an organic substance. So, infections. So how can infections occur? Well, what if you take the blood out of the fridge and let it sit on the counter for an hour or two? Well, that increases the chance of an infection developing within the blood even before it was transfused. Okay, so that's why blood is typically taken out of the fridge, and the longest it can stay on a counter, typically it's not left on the counter, is 30 minutes. It's typically given pretty fast, okay, to avoid the potential for a bacterial infection. Now, within the blood itself, because it's donor blood, well, hepatitis B, hepatitis C, or even HIV, okay? Those are heavily screened for now in donor blood, okay? So it's very, very rare to acquire hepatitis B, hepatitis C, or HIV in a blood transfusion. It's still possible, but it's an extremely remote event now because of all the screening of the blood products. Okay? Now, sepsis can occur, and I was talking about this a bit earlier when I said leaving it on the counter for a period of time, and that's where bacteria can start to grow within the blood. So improper handling or storage, say the fridge didn't work and the blood sat there in a warm fridge, well, that could lead to bacteria within the blood. And when this occurs, patients can develop bacteremia or even sepsis from the bacteria that's now grown within the blood itself. And this will lead to high fevers, chills, hypotension, shock. So sepsis is a possibility, but again, it's very uncommon because the fridge is closely monitored. The nurses know not to leave the blood on the counter and to infuse it quickly and not allow it to warm up too much to prevent bacteria from growing within the blood. Okay, so I'm going to try and speed up here. I know I'm going over time. It's very difficult to cover all these topics in 2.5 hours. So let's look at the next slide, blood component therapy. So what is the role? What's the nursing role? Well, typically we use a larger needle, so an 18 gauge needle, okay? The higher the number of the gauge of a needle, the thinner and the smaller the bore of the needle is. So an 18 gauge or a 16 gauge needle is a bigger needle, okay? We need correct tubing to give blood with a filter on it. We don't mix blood with dextrose solutions like D5W or lactated ringers. So nothing else goes into that line. It's dedicated for the blood transfusion. The identification process of the patient and the donor blood is really important, okay? And it's double checked. Checking baseline vitals even before the blood is transfused so that we know if something occurs during the blood transfusion, we know that the vitals have changed. Say someone becomes tachycardic or hypotensive, okay? Using the blood within 30 minutes of receiving the unit from the fridge, okay? Not leaving it on a counter for a prolonged period of time. Typically staying with the patient for the first 15 minutes to make sure there's no immediate reaction that's occurring within the patient. Starting the blood slowly, 2 milliliters per minute initially, slowly to make sure there's no significant reaction. And finally, the blood has to be transfused within 4 hours. Because if it's longer than that, the blood has had a long time that's been hanging there, and it can lead to bacteria within the blood that's being transfused. So 4 hours is the maximum length of time to transfuse red blood cells. Okay, let's do a question. What can be transfused? Choose all that apply. Packed red blood cells, for sure, for anemia. Platelets, for sure, for thrombocytopenia. Plasma, we give in the form of what's called fresh frozen plasma, and that's to replace clotting factors, right? So that's the main reason for giving fresh frozen plasma, to replace clotting factors. What about D, clotting factors? Well, they can be transfused in someone, say, with hemophilia, right? So instead of giving someone with hemophilia straight plasma, we now have synthetic clotting factors, so they can be transfused. And lastly, albumin. So albumin is considered a blood product, and we can also transfuse albumin. So it's all of them. They can all be given.